Thank you everyone for joining our third webinar series, ISPD series today. We will have two speakers today. Dr. Darwish is going to be our moderator. I'm going to introduce her, and then she is going to introduce our two eminent speakers. So Dr. Darwish is a trilingual consultant nephrologist at Qasr Al Ain Medical School in Cairo. At Cairo University with over 25 years experience in public and private practice. She has a strong passion for education and is actively involved in various international nephrology and community healthcare forums at both national and international levels. She, since joining the AFRAN family as a PD chair committee and later as a treasurer, her major professional and community support interests are within the context of providing and improving adequacy of kidney care and replacement therapy in Egypt and Africa. She managed with her team to arrange the first AFRAN PD training course in Tunisia, as well as in Senegal with collaboration of ISPD and SOS-ENT. She is hoping to bridge the gap between our African continent nephrologists and the renowned international nephrology institutions through her positions as the ISN Dialysis Working Group member, representing Egypt and Africa, and ISPD Nominating Committee member, representing Middle East and Africa. It is an honor to have you, Dr. Darwish. Please take the lead. Thank you.
Thank you so much, Dr. Mazhar, for this very nice introduction. And thank you for Africa Healthcare Network for the effort you are continuously doing to improve nephrology education throughout our continent. And this is the third webinar in collaboration with the ISPD, trying to cover the major topics which are of interest in peritoneal dialysis. Thank you so much. I am honored today to introduce our first speaker of today's webinar. Dr. Matthew Rivara, MD, is an associate professor of medicine at the University of Washington and the chief medical officer for Northwest Kidney Centers in Seattle, USA. He earned his medical degree from Harvard Medical School. He completed an internship and residency of internal medicine at Massachusetts General Hospital and a fellowship in nephrology at the University of Washington. Dr. Rivara's clinical and professional interests are in the care of patients undergoing dialysis with a specific focus on home dialysis therapies, hence his topics, and he's talking today with us about PD. He has actually also served on the steering committees for multiple work groups of the Kidney Health Initiative and the KDIGO, and he serves on the Council for the North American chapter of the International Society of Peritoneal Dialysis, where he's also the co-chair of the ISPD North American Chapter Education Committee. He serves on the faculty of Home Dialysis University and the author of over 50 peer-reviewed articles and book chapters on a variety of topics in end-stage renal disease and home dialysis. We are very, very honored, Dr. Rivara, for you to have joined us today. And we are waiting for you to talk to us today about non-infectious complications of peritoneal dialysis. Dr. Rivara.
Great. Thank you so much for that very kind introduction. And it's really a pleasure to be here. Again, thank you so much for having me. It's a real pleasure. And I've really enjoyed working with the ISPD over the last couple of years. Have both worked with ISPD International, where I'm on the education committee, as well as more recently with the North American chapter on the council there, and love talking about peritoneal dialysis. So I was assigned today to talk about some non-infectious complications of PD, as I understand that some of the other major topics, including peritonitis and infectious complications, are covered in other sessions. So this is, we're going to dive right into it, and, we'll be done with this section hopefully in about 25 minutes or so before transitioning to my colleague, Joanna Neumann. This is the outline of what we're going to be talking about. So separated the complications into a few different categories. We have complications related to increases in intra-abdominal pressure in PD, some other intraperitoneal complications. There are a number of metabolic complications other than hypokalemia, but that's what we're going to focus on given time constraints, a little bit on infusion and drain pain, and then the sort of most feared long-term consequence of PD called encapsulating peritoneal sclerosis. All right, so the first comment to make about complications related to intra-abdominal pressure is that there is there are associations between intra-abdominal pressure, both with the volume of fluid that is filling the abdomen, but perhaps more importantly is the patient's position. So this is a figure from a paper that's now 40 years old, but still very relevant, which shows on the x-axis the intraperitoneal volume in liters. And then on the y-axis shows the intra-abdominal pressure in centimeters of water. And the different lines are the different positions that the patient may be in. By the way, I apologize, I can't see the Q&A during the talk, so people are welcome to interrupt me if needed. I'll let the moderators do that. So what you can see here is, in general, the larger the intraperitoneal volume that's put in, the higher the intra-abdominal pressure. But there's a dramatic impact of position, with the supine position having the lowest intra-abdominal pressure, followed by standing, and actually sitting has the largest intra-abdominal pressure, such that the intra-abdominal pressure with a patient supine filled with 3 liters of fluid is just about the same as actually less than 1 liter of fluid in someone who is standing or sitting. So that supine position dramatically lowers intra-abdominal pressure, which is important in thinking about how you might prevent or even manage some of the complications that we'll talk about. So the first is our hernias. And the first thing to just say about that is that most hernias are present prior to the start of PD, and it is just the increased intra-abdominal pressure that accompanies the installation of the PD fluid that makes it evident. And so we generally, at the time of PD catheter placement, if it is done in the operating room rather than at the bedside, can be very helpful to inspect for the presence of hernias. But even before the OR, at the time that the PD catheter placement is being planned, to carefully inspect for the presence of hernias. And if possible, they can be either fixed either at the time of the PD catheter placement if it's happening in the operating room, or prior to PD catheter placement if a surgeon is not placing the catheter. The prevalence of hernias in patients on PD is estimated to be as high as 25%, and that includes obviously multiple subtypes inguinal hernias that represent probably 50% of hernias seen in PD, some of which are related to patent processus vaginalis. And then, of course, umbilical and then ventral hernias for individuals in particular that have had prior abdominal surgery. Why hernias are so prevalent in patients on PD is thought, almost certainly to be related to the increased intra-abdominal pressure accompanying the installation of PD fluid into the abdomen, but also, thought potentially to be contributed to by weakened connective tissue that's not necessarily well understood in patients with advanced kidney disease. So how do hernias present? Well, generally it's going to be similar to other presentations of hernia, but it's going to be present in relation to when fluid is in the abdomen. So for patients with an inguinal hernia, groin swelling and discomfort, particularly upon installation of PD fluid, could be confused with a scrotal mass. For patients with an umbilical hernia, it's going to appear as periumbilical swelling, of course, an obvious incisional hernia, but could present in some more subtle ways as well. So for a patient that's on PD already and develops a hernia later into their course, given that fluid, the dialysate is going to be sequestered in that hernia sac, patients may present just with failure to ultrafilter as part of their PD treatment. So that's something that ultrafiltration failure or challenges should prompt a physical examination for signs of hernias. Other presentations, you could see just an unexpected low solute clearance or ineffective PD in terms of adequacy, again, due to dialysate sequestration. Less commonly, true bowel obstruction or incarceration, a tender lump. And then something that's been reported a number of times is patients with unexpected recurrent gram-negative peritonitis, where you're getting bacterial translocation, again, because of sort of sequestration of fluid that's then remaining stagnant. So one question that comes up sometimes is if you do identify a hernia after starting PD, does this require a transfer to hemodialysis? And people have studied this, at least at the case report level. And in general, the answer is no, unless the patient has bowel compromise in some of those more unusual presentations, or a patient is anuric and particularly predisposed to fluid overload. And they're in this paper that I've referenced here from Peritoneal Dialysis International, the authors propose a suggested regimen. If you do need to do a surgical hernia repair, if the patient has significant residual kidney function, like over 4 mLs per minute of GFR, you could consider just halting dialysis for a week, for example, and then starting lower volume PD afterwards in a supine presentation, again, to prevent leakage and problems with the incisional healing. If patients don't have residual renal function, people have proposed actually you can just halt dialysis for 1 to 2 days and then start not only low volume, but actually intermittent peritoneal dialysis, perhaps for the first week, just 3 times per week. Most patients that you all take care of are likely to be on CAPD, and so you could even do this for 2 weeks. And then after that, going back to daily peritoneal dialysis, but again with lower volumes, 1 to 1.5 liters for an additional 2 weeks, after which you can resume full dose PD. So this is a way to prevent the need for temporary transfer to hemodialysis. Moving on from hernias to some other complications from increased intra-abdominal pressure. The next one we'll talk about is external leakage. So the clinical presentation for this, which occurs most often early, so within 30 days of peritoneal dialysis catheter insertion, is going to be a moist or wet dressing, or even obvious leakage of clear fluid around the PD catheter. Now, sometimes this can be confused with just some sort of serous discharge, or even, could be confused sometimes with an exit site infection with, purulent discharge. But the key here, of course, is that this is clear fluid and usually is pretty evident. So the diagnosis is usually just purely clinical based on observation in the history. I'll talk in the next slide about one other thing that one can do easily. Management of this, if you can, given that it often occurs early in the need for dialysis and people have residual kidney function, would be to just postpone peritoneal dialysis initiation by a couple of weeks to just, again, let more healing occur around the PD catheter cuffs. If it's not possible to postpone, you can just try switching to a low volume, so 1 liter fills or less, maybe even 750 cc's, and then doing PD only in the supine position. Surgery with catheter removal and replacement may be needed if this doesn't solve the problem and there's recurrence. The other thing to just consider is that because leaks indicate that there is a communication between the intra-abdominal space and the outside of the body, that they may be associated with an increased risk of peritonitis or a tunnel infection. So some providers will treat with prophylactic antibiotics at the time the leak is noted. So if you're not sure whether the fluid that you're seeing wetting the dressing is a serous ooze or actually a dialysate leak, of course, using a dipstick, urine dipstick, for example, to look for glucose can be helpful, remembering that all PD fluid, even lower glucose content like 1.5% dextrose dialysate, is substantially hyperglycemic and will show very positively on a urine dipstick. So the only caveat is if you have a patient that is severely hyperglycemic, then you could get a positive dipstick even with a serous ooze. Internal leaks can also happen, and they often happen later than external leaks, after 30 days after PD catheter insertion. Could occur as genital edema and abdominal wall edema, so kind of pitting edema where it looks almost like anasarca, but is going to be more localized in the abdominal wall or down in the genitalia. Again, just like hernias, apparent ultrafiltration failure could be a sign of internal leakage. The diagnosis can be purely clinical if it's very obvious, Unfortunately, sometimes if it's not obvious, you may need imaging, and what is typically recommended, if it's available, is CT peritoneography, where actually iodinated contrast is added to a dialysate bag in a sterile fashion, and the dialysate is infused in the belly. The patient is instructed to sit or stand for an hour or so to increase the intra-abdominal pressure, and then a CT scan is done to look for iodinated contrast that is in places it shouldn't be, like in the soft tissue or down in the genital space. So this is, an example, in this case, a patent processus vaginalis, and fluid is not a hernia per se, but fluid actually leaking down into that space and being evident in the scrotum in this case. What is the management of internal leaks? So we talked about imaging. Temporary interruption of peritoneal dialysis is often needed in this case, although if it's a minor internal leak, again, switching to lower volume supine peritoneal dialysis to take advantage of that lower intra-abdominal pressure can be trialed, and then surgical repair may be needed in some cases. The last complication related to intra-abdominal pressure that I'll mention is hydrothorax. So what is this? This is accumulation of peritoneal dialysate in the pleural space. It is, for reasons that aren't totally understood, more often noted on the right side of the body as opposed to the left side. And it's thought to occur because of some pre-existing defects in the diaphragm rather than a de novo generated defect. And then as you get increased intra-abdominal pressure, fluid can then move to the pleural space from the peritoneal space. Interestingly, these often will happen months or years into someone's PD course. So why it occurs then and not earlier in the course is not well understood. It tends to be rare, so less than 5% of PD patients, but certainly in my practice over the last 10 to 12 years, I've seen 3 or 4 of these, and so it will occur. Diagnosis and therapy, both often thoracentesis is needed because the entire pleural space can fill on one side and cause actually lung collapse. And then you're going to see a transudative effusion, and then often, but not always, a very high glucose concentration. So why might you not see a high glucose concentration? Well, if the fluid has been sitting there for a day or longer, that glucose is going to be absorbed, and so you could get a case of even a glucose concentration similar to the blood, or maybe even just very slightly higher. So just something to remember. What is management of hydrothorax? So we've talked about the thoracentesis. Some reports, including this one that I've mentioned here, really state that it may be possible to continue peritoneal dialysis in up to half of cases if you, again, convert to supine, low volume PD only. In my experience, however, most cases, in my case, 3 out of the 4 cases required a transition to hemodialysis because it didn't resolve. And if the patient would like to continue on PD, then you may need to do definitive management, either operative repair of the defect or pleurodesis. If a patient chooses to stay on hemodialysis and not go back to PD, then you may not need to do an operative repair because it's not going to be evident without, again, that increased intra-abdominal pressure and fluid in the peritoneal space. So that was the longest section, but moving on to some other complications. So other intraperitoneal complications. The first is hemoperitoneum, which is very common. And the reason it's very common is that a very small amount of blood can change the color of the peritoneal effluent to bright red. So even less than 5 milliliters of blood in a 2-liter bag or 6-liter bag can turn it pink and if not bright red. The appearance is alarming to patients in particular, but the reality is generally not as bad as it looks. The blood can originate from a number of spaces. So the peritoneal membrane itself, and we'll cover the causes here, the visceral organs in the abdomen or the pelvis, or even the soft tissues in the abdomen, and then leak into the peritoneum. This is just a rough overview of potential causes. So, by far in menstruating age females, the most common cause is going to be menstruation itself, remembering that there is a communication between the fallopian tube in the intra-abdominal space. And that is something that younger female patients should be counseled on. Endometriosis and rupture of ovarian cysts are a relatively common cause as well. There are some GI and urologic causes. So after a colonoscopy, for example, you may see this transiently, and then GI tumors and other liver cysts. The peritoneal membrane itself, if you have someone who has the complication we'll talk about at the end called encapsulating peritoneal sclerosis, you can get some hemoperitoneum, or patients that have prior radiation to the abdomen. And then some other miscellaneous cause, patients that are on anticoagulant therapy, for example, may notice this occur sporadically. So what is the management? Obviously addressing the underlying cause. If it is menstruation, it's just going to be transient. You can consider adding unfractionated heparin to the dialysate bag at a concentration of even just 500 units per liter to avoid fibrin clotting, which would be the primary concern, clogging the catheter. Just remembering that you're not really at risk for systemic heparin absorption because it doesn't get systemically absorbed very well from the peritoneal space. And then there is some evidence that rapidly flushing the abdomen with even room temperature dialysate, which is sort of relatively cool to body temperature, can cause vasoconstriction of blood vessels in the peritoneum and lead to cessation of the hemoperitoneum. I'll just mention briefly another kind of alarming presentation, which is very rare. I've only seen this once, is chyloperitoneum. Obviously, chylous fluid in the peritoneal space. It's a white, milky dialysate caused by the presence of triglyceride-rich chylomicron particles. Generally, you're going to see triglyceride concentrations of over 100 milligrams per deciliter in the PD fluid if you mention it, if you measure it, but it's usually going to be quite obvious. The physical appearance is the effluent, and there's very rarely a need for other diagnostic workup there. Because of the causes, which I'll talk about in a moment, the therapy is generally going to be at least temporary cessation of peritoneal dialysis. So what are the causes? So abdominal malignancy causing lymphatic duct obstruction. It's really anything causing obstruction or damage to the lymphatic duct is what's going to cause this. Could be infectious causes like tuberculosis, malignant causes like lymphoma, or traumatic causes. I work in a trauma center, and so I've seen this a couple of times from abdominal trauma in motor vehicle accidents. Sarcoidosis has also been reported to cause this, and then major abdominal surgery when there's been either inadvertent or necessary damage to the lymphatic duct. So to move on to the sort of one metabolic complication we'll talk about, which is hypokalemia. Just as a reminder, of course, that hypokalemia is much more common in peritoneal dialysis compared to hemodialysis. This is a paper from 10 years ago, just simply looking at the concentrations of serum potassium in PD versus HD, showing that hemodialysis patients more likely to have serum potassiums of 4.5 to 5.5, whereas peritoneal dialysis patients much more likely to have potassium concentrations of less than 3.5 or 3.5 to 4. Why do we note this? So certainly there is some potassium that is lost in the dialysate, and commercially available dialysate does not contain potassium. But careful studies of the potassium content in the effluent indicate that that's probably not enough to account for hypokalemia in most cases, although if you combine it with low potassium intake in certain countries and dietary causes that could generate it, there's thought to be probably some transcellular shift or absorption of potassium into cells caused by insulin release in response to glucose absorption from the dialysate is probably a substantial cause. And then PD patients are more likely to be on diuretics and laxatives, which may cause systemic potassium removal. So these are the causes that are thought to be contributing. The treatment of hypokalemia in peritoneal dialysis could be multifold. So one is just recommending increasing in dietary potassium intake if that's available. Certainly oral potassium supplements may be needed either in a proactive fashion or a reactive fashion. So there's been more interest lately after a publication about a year ago of a clinical trial from Thailand showing that higher serum potassium through a proactive supplementation strategy decreases peritonitis incidence. There's been more interest in more proactively maintaining higher potassium concentrations with proactive supplementation. Spironolactone, a potassium-sparing diuretic that has been around for decades, has been shown to increase serum potassium in PD patients by 0.5 ml equivalent per liter. So could be an option if potassium supplements are not available or patients don't tolerate them. Generally, we don't recommend adding potassium to the PD fluid because it violates the sterility of the PD fluid and just adds extra steps, but has been noted to be done in some instances. Infusion pain and drain pain, and we're getting to the end here. So infusion pain is most common soon after peritoneal dialysis start in incident PD patients. It generally gets better over time in most people. We think it's related to the body adapting to the lower pH of PD solutions or even existing intraperitoneal adhesions. It can be caused through the accidental infusion of air, although that is not very common. Or if you have a patient where there's some issue with the dialysate temperature, in patients who have access to peritoneal dialysis cyclers, if there's a malfunction of the warmer function on the cycler, you could see this. Because we think the pH is probably contributing mostly to this, some investigators have described spiking bags with extra sodium bicarbonate. And here's the amount that has been recommended, about 5 millimoles per liter. I've not done this myself because in general, again, this is resolved quite quickly, but this is an option. And then perhaps more common than infusion-related pain is drain pain. And they're much more common in patients that have access or are using an automated PD cycler, which drain fluid via hydraulic suction rather than gravity. And also cyclers are designed to have a safety function to drain the abdomen completely at initial connection that can't be overridden. In patients on manual exchanges, this is much less common, but it still can occur. The parietal peritoneum is sensitive to negative pressure, whether it's generated by gravity or hydraulic suction. And then some centers have described a center effect. So certain surgeons may have patients where they place catheters and may be more likely to have drain-related pain, and we don't totally understand that. The management of drain pain, just like so many things in peritoneal dialysis, is laxatives and avoiding constipation. As I mentioned, patients on CAPD with manual exchanges are less likely to have this. If you must use a cycling machine, then to try tidal peritoneal dialysis, which is where not all of the fluid is drained out before the next fill occurs. Repositioning the PD catheter has been described. It has happened to me at least once or twice where this was so severe and we couldn't reconcile it and a patient had to switch to in-center hemodialysis, but that should be a last resort. And this is the final complication, which is just a long-term complication of peritoneal dialysis called encapsulating peritoneal sclerosis. So this is characterized by intraperitoneal inflammation and fibrosis, which encases bowel loops, causes ultrafiltration failure and bowel obstruction, and unfortunately has been associated with very high mortality, like up to 40% at 1 year. Fortunately, it is rare, but the major risk factor by far is the time on peritoneal dialysis, as well as the severity and the number of peritonitis episodes that have occurred. The true pathophysiology still is not totally understood. Imaging on abdominal plain films, it can be shown basically to look for, it's usually a non-obstructive bowel pattern on the abdominal plain film, but you'll see multiple linear calcifications corresponding to the bowel wall that can be sort of tethered more towards the center of the abdomen rather at the periphery. CT scan, if it's available, will definitively show this with peritoneal calcification tethering to the center of the abdomen and bowel thickening. The clinical presentation, there's really two phases. An earlier inflammatory phase sometimes can be missed because the symptoms can be features of other conditions. So anorexia, nausea, weight loss, vomiting. You can get hemoperitoneum, as I previously mentioned. Peritonitis can occur, though, without an identified organism. And then there's a later sclerosing phase, which is often where things are diagnosed, where you get recurrent bowel obstruction, progressive malnutrition, and UF failure. And again, this is what a CT scan would look like with tethering of the bowel loops to the center of the abdomen, and then pathology. This is what it would look like. Generally, operative intervention is not recommended because it can be so easy to puncture the bowel when operating on this. And so even if people have bowel obstruction, you can sometimes cause further harm by trying to have surgical repair. The treatment, which again is really just case series level data, is prednisone and tamoxifen, and then supportive therapy with nutritional support. So I think that's all I have. I'll stop my share and then can turn things back over to the moderator for next steps.
Well, thank you so much, Dr. Rivara, for this very elegant presentation. I mean, I personally enjoyed it very much. It's extremely clear, simplified, yet you covered all the major complications in focus, and it was very, very informative. Thank you again. We really appreciate it. Well, I guess I will have to move now to our second speaker. I am honored to present today Ms. Joanna L Neumann. She has been a nephrology nurse for more than 36 years and 33 years in satellite healthcare, where she has worked at different roles. Her current position is a Senior Director for Quality Clinical Services. Ms. Joanna presents regularly at the ADC and the ANNA certification review course. She has served as an author, co-author, and reviewer for different nephrology curricula. Ms. Joanna is an active National Kidney Founder volunteer, a board member for California Alliance for Kidney Care, a member of the International Society of Peritoneal Dialysis Nursing Liaison Committee, and the nurse representative of the ISPD North America Chapter Council. She is actually the recipient of the 2024 Barbara Prowant Lifetime Achievement Award in Nephrology Nursing. Ms. Joanna, first, congratulations for your award. I'm sure it's very well deserved. And we all know very well that a PD unit wouldn't be successful unless we have a very strong and dedicated nurse. We all know that. And we are looking forward to hear from you, from your experience about how to be running a PD unit from the nursing point of view. Ms. Joanna, please.
Thank you, Dr. Rasha, for the nice introduction. And just want to make sure, are you hearing me okay, everybody? Sound check. Yeah. Okay, great. Thank you so much. And thank you for the invitation. I feel very honored to be invited. And I'm assigned to talk about running a PD unit, the nurse's view. And I have nothing to disclose. And the objective for this presentation, okay, after the presentation, the participant will be able to discuss the factors that contribute to a successful PD program, and then identify important attributes to be a leader for PD clinic. List 5 main responsibilities of a PD nurse manager, describe the role of a PD nurse, and then state the daily routine for PD nurse. So in order for us to have a good program, there are some characteristics. Definitely we need to have a good infrastructure and then a good size PD program. So if you ask, so what do you mean by a good size PD program? There are variation of opinion about that. But usually we talk about maybe anywhere 25 to 50 patients. Because if you don't have enough PD patients to take care of, the nurses and the staff member does not have enough exposure to build up that experience. And then in order for the infrastructure to work, more patients is better. And then that leads to the next point, to have a good CKD education program, because that's the segue to increase your PD population. And I'll talk a little bit more about that later. And definitely we need to have qualified physicians and nurses that are well trained on PD, just like how Dr. Rivara talked about all the management of complications. You see, we take some qualified physician with the experience to manage those complications. And then the next thing that we cannot look take lightly is the good relationships with the surgeon who placed the PD catheter. I'll elaborate that. And then definitely we need to have a sound PD training program and also the follow-up process. And the policies and procedures that support the operation and patient care for the clinic has to be evidence-based. We have to have the interdisciplinary team, doctor, nurse, social worker, dietitian, and then last but not least, the office support. They are one of the key members to keep this center going. And then the care team being able to manage the patient's complications, no matter it's infectious, non-infectious, or any others. And then we have to have a good continuous quality improvement process and program in place, and definitely a robust governing body to oversee everything for the center and for the program. So the daily manager is the nurse manager for the center, for the clinic. Okay. And besides being a manager, we need to have a very good leader. So what kind of qualities are we looking at? The leader needs to be able to communicate effectively, act as a role model, foster a positive work environment, okay, embrace the people, embrace all the practices, has to be advocate for the staff, to be fair, and make sure that the staff can do the work safely, and then also care about the well-being of the staff, the patients, and the loved ones. And then we have the nurse manager need to be on the lookout, be proactive, to be aware of the staff burnout and compassion fatigue. You know, the PD nurse is a little bit different than some other regular hospital nursing. We take care of these chronic patients. We see them day in, day out, or, you know, on an ongoing basis. We establish relationship with these patients. And then sometimes because of this intensive relationship, we can get compassion fatigue. So when the nurse manager talk to the nurses or listen to them report the patient's condition, we need to be unaware of the burnout and then do the appropriate counseling. Promote teamwork and have good time management, embrace change. You know, the only thing that is not change is change. We are undergoing continuous change nowadays. So we have to be a good change agent and then lead the team to accept it. And then also commit to lifelong learning. Okay, so we can break down the nurse or the leader responsibilities into 5 big categories: facility, operation, patient, personnel, and fiscal management. I'm going to go through that one by one. Okay, the facility management. We need to be able to follow the legislation and the regulations. In the United States, it's quite heavily regulated. So the company that run the center has to have the infrastructure and the policies, and then it is upon the nurse manager, the leader, to follow those local legislation and regulations. And then of course you have to follow the company policies and procedures. And then in order to make sure these policies, regulations are being followed, the nurse manager has to establish some kind of process to perform audit to make sure they are in compliance. And then building management, the building maintenance, work with the other department to make sure that the building is nicely maintained, no chip off paint, no leaking ceiling, anything, okay? And then provide a safe environment for the staff and for the patient, and make sure that the building is up to code. And then, of course, all the equipment and appliances must be checked regularly to ensure safety. And then the next thing, very importantly, infection control. And hopefully the unit is designed to facilitate the ease to practice infection control. Okay, so people don't have to walk through a bunch of area with specimen. Okay, that is not good infection control practice. And then so the manager has to enforce and be compliant on this infection control practice and do audit and observe different procedures by different staff to make sure that they are compliant to infection control. And then definitely we need to have designated containers for shops and for biohazardous waste. We cannot mix those with regular trash. Another important function for facility management is emergency preparedness. We call it emergency. That means we didn't expect it, right? It happens. So the company and the facility has to have very sound and good emergency preparedness plan, and then do the drill accordingly. And then it's specifically for the local area. So we have one center that is next to a train track. So in order to prepare for emergency, we actually establish a plan in case the train derail. What do we have to do? Other thing is like earthquake, hurricane, storm, something like that. Okay. And then for our home patients, they might not be in our center when the disaster or emergency happen. So it is very important for us to establish the plan to educate patient what to do in case of an emergency. Okay, next is the operational management. I mentioned earlier, we have to have a very robust pre-ESRD, ESKD education program. Those are the pipeline. We need to educate the patient or the CKD client what the treatment options are so that they can make an informed decision. And this was mentioned a lot of different literature when I did my literature search. They talk about a very standardized pre-ESRD education program is critical, because if a patient get educated about all the in and out pros and cons for dialysis option, a lot of them will actually choose PD. Okay. And then we have to have this program on a regular schedule and also on demand, because a physician, when they see the patient and they see that the patient is approaching ESKD, it can be stage 3 or 4. They want to pick up the phone and call you and say, this patient needs pre-ESKD education, and this patient is approaching stage 5. Can you see the patient right away? We don't want to say, no, my class is in 3 weeks. Yes, doctor, we can see the patient right away. Okay, so we need to communicate with the nephrologist or the case manager. When do we have the program? What do we talk about? And then follow-up communication is very critical. It will be nice to have a written letter or pick up the phone and talk to the nephrologist. Hey, I saw your patient Jane, and the patient is very interested to do PD. So please let us know what will be the next step, or when you start to refer the patient to a surgeon, so that we can be in touch with the patient. Establish that relationship. Okay, and then patient selection is another one. We need to be able to do some home visits, assess the patient home environment to get rid of the barrier to start the patient on home therapy. And then do some recruitment. And even for us, we will have some lobby day. We go to the in-center hemodialysis clinic and talk about PD option so that they can make a decision if they want to stay on in-center or they might want to do a home therapy. A lot of these patients, especially the one that crash in, they never got a chance to listen to the option education. So by reaching out to them is a good way for them to learn about the option and for us to recruit some more patients to be on PD. Okay, operationally, we need to have a good patient training program, standardization. If we have a standardized training program that incorporate adult learning principle, even though the patient might be trained by an assigned nurse, if that nurse is busy or calling sick, another nurse can jump in and continue without interruption. The training material would be nice to have different languages for the area that I'm practicing in, we are very diverse. So the need to have the training material in different languages is very helpful. And we follow the ISPD patient training curriculum and utilize qualified trainers to do the training. Okay, so for the patient to have good understanding of the material, a qualified, experienced trained nurse is critical. And the nurse needs to be able to really utilize the adult learning principle and adjust the training style according to the patient's learning style. Okay, and then we need to provide the option to train the patient and the care partner at their own home if they cannot come to the clinic. And sometimes it might be even better to get trained at their own home so they don't have to transfer what they learn at a clinic setting to the home setting. Everything is set up for them. And then last but not least, we need to be able to standardize our documentation, no matter it's electronic or paper. Documentation can serve as a good communication tool. And also, we always say, if you don't document it, you cannot prove that you have done it. And it helps for the next nurse to take over when they have to take care of the patient to see what had happened. And then communication. As a nurse manager, he or she needs to be able to communicate, work closely with the medical director for the clinic, and outreach to the referring nephrologist. And then so that the nephrologist will refer more patients to the clinic. And we call it, the front office staff are the gatekeeper. Because when we call, we always talk to the front office staff. We need to establish that relationship so they know who you are and say, hey, I want to talk to Dr. Rivara. Oh, yeah, just 1 minute. Oh, hey, by the way, do you have any new patient that needing ESKD, pre-ESRD education? You can refer to us. They can help with that too. And then I talk about the close communication, good communication with the surgeon. We can help mark the catheter exit site before the patient gets seen by the surgeon so that the nurse can discuss with the patient, hey, are you left-handed or right-handed? Which side is better, okay? And then talk to the surgeon about preoperative antibiotic coverage following ISPD guideline. And most importantly, once the catheter is placed, communicate with the surgeon about the catheter outcome. I was in touch with a surgeon, not for the best way because a lot of the catheter outcome was not good. And then during my conversation with the surgeon, he said, I'm just a technician in the whole process. You guys just tell me when there's a problem. It dawned on me that, yes, you're right. Why do I always have to deliver the bad news? So I started the process, the procedure. I will call the surgeon every single time. And in particular, he plays a very good catheter to give him the kudos. So he get the job satisfaction. He doesn't feel like you only call me when there's a problem. So we establish a very good working relationship. And then, nowadays we like to have some short huddle. We group all the staff together, just do a powwow and talk about, hey, what's going on today? Do we have any patient that has some infection we need to take care of, and any special procedure, any change, so that everybody will be on the same page. Everybody will be well informed. And then besides the short huddle on a daily basis, we need to have a monthly staff meeting. Because as a nurse manager, you get instructions from the leadership team, from the executive. How do we communicate those information to the center staff during the staff meeting? Talk about the quality, okay? Talk about the outcome. How can we improve? And then the governance meeting for the clinic running. And then the nurse manager is also responsible for preventing attrition of the patient because we want to keep our census up to provide patients with the privacy, listen to the patient's grievance and deal with it. Supplies. Okay, sometimes some of the staff might feel like, well, these are not my money. I can give the patient any supplies I want, or I can use supplies casually. But supplies cost contribute to the operating costs for the center, for the clinic. And subsequently, that is translate to our paycheck. So when I talk to the staff, we need to, even though this is not our money, even though this is not out of my pocket, but if you think about it, however money we spend to take care of the patient can directly affect our paycheck. So please be mindful. So we need to teach the staff how to be mindful on using supplies and subsequently leading to the supply cost. We need to manage all the recalls, make sure that we track them, talk to the patient, because the supplies are not necessary just in the clinic. It can be at the patient's home. So we have to have some recall process, and then medical records management, and then manage the unusual occurrence incidents, say for example, a needle stick at the clinic. Okay, patient management. We need to be able to manage the patient's admission and discharge. Okay, and assign and match the training nurse. Keep in mind the nurse to patient ratio. There's no magic number. Okay, it's different in different country. And even within the United States, we have a little bit of difference between different states. But then as a nurse manager, maybe you can match the language need. If a patient speaks different dialect, match the nurse that can speak the same dialect as the patient, and then consider the nurse's patient load. If the nurse already taking care of a lot of patients, training 2 other patients, adding 1 more might not be the best decision. Sometimes a nurse manager need to be able to jump in and take care of some of the patients so that we can help the nurse, lighten up the nurse's load so that the nurse can do a good job. And then also we need to match the personality if we know about it. And patient's peer mentor. Sometimes if we can match a new patient with a existing patient who share the same background, patient to patient talk is so much more effective, efficient, persuasive than us, because we're not on dialysis. And we need to be able to manage the patient's schedule so that we make sure that the patient is scheduled at a time that is convenient to the patient. And also, we're not scheduling a lot of patients to be seen so that the nurses are overwhelmed, or we don't have enough space to see all the patients at the same time. Manage quality outcome. Anemia, adequacy, mineral bone disorder, infectious and non-infectious complications, hospitalization, and mortality. Okay, and then interdisciplinary team coordination. The nephrologist, nurse, dietitian, social worker ensure the team members are doing what they need to do for the appropriate intervention. Make sure that somebody or the social worker in particular is looking at the advanced health directive, and then the patient's adherence to the treatment, patient financial challenges, home visit as needed. Vaccination, COVID-19 vaccine, flu vaccine, hepatitis B, pneumonia vaccine, manage patient's home supplies and patient satisfaction, manage dropout of PD. You can see there's a lot to do about patient management. And then the next thing, we need to manage the personnel. As a manager, we're managing the staff at the center. We need to be mindful about the scope of practice per regulations. We cannot just ask a office staff to train a patient, okay? Has a full awareness of the patient as for the employee's job description. And then the manager is a hiring manager responsible for interview, make sure they have done the orientation, the training, and coordinate with the education department. Don't forget to do one-on-one with the staff, because an ongoing basis and provide feedback is important. We don't want to wait until the evaluation time and then tell, hey, you haven't been doing this well enough. And then the employee will say, why didn't you tell me all along? Right? So ongoing feedback, constructive feedback is good. And some praising is great. And then discipline, if we have, it's hard. Nobody likes to tell somebody, hey, you're not doing something good. but this is critical. Otherwise, if we allow the undesirable behavior as happen in ongoing, that will affect everybody at the clinic. And then we also have to deal with separation. And then some other one is like keeping record, certification tracking, employee schedule, make sure that we have enough staffing, payroll, bonus, take care of leave of absence, and track any injury on duty. Do we have to do compensation? And ongoing training for any new procedure and equipment. Make sure the staff is trained, well trained, and qualified before we ask them to train the patient. And it's very important to provide opportunity for them to take some time off to attend conference or webinar like this and do the annual competency. Make sure the staff has the competency to take care of the patients, and then perform and give them time to do any mandatory training and keep track that they are up to date. And should the staff follow for policies and procedures, keep the employee informed of everything that is going on with the company, with the clinic, with the patient, and listen to employee feedback. And better yet, if the company has an employee satisfaction survey, so they can do it centrally and then gather the information to make improvement. Employee satisfaction, if you have a satisfied, happy employee, you will have satisfied, happy patients. And then the next thing is financially. You know, the manager need to manage the operating cost, supply costs, labor hours, avoid paying the staff overtime because that's a lot of money. Manage patient census, billing, okay, contract pricing with vendors. Sometimes some of the vendors will charge extra for extra delivery, late delivery, or anything if you pick up a machine. So we need to be, as a manager, we need to be mindful of all those extra charges and avoid them. And then minimize any waste. Now, after talking about being a manager, let's talk about a PD nurse, because PD nurse is a critical, crucial member of a PD clinic. And look at it. This is a quote from ENNA back in 2004. It's quite a while ago, but it's still applicable. A PD nurse is an educator, clinician, care coordinator, leader of the healthcare team, patient advocate, consistent member of the healthcare team, coordinate and a consistent and clear plan of care of the patient, establish trusting relationship with the patient and the care team, empower the home patient. Why is the role of a PD nurse so extensive? Because they see the patient the most. When the patient has to go through training, the nurse spends most of her time to train the patient. When the patient has issue, has problem, they pick up the phone and they call the nurse. And during monthly or weekly clinic visit, the patient see the nurse. So the nurse has the most exposure, and that's why they have so many responsibilities towards taking care of a patient. So day to day, they have to manage the schedule, okay, on a monthly basis, plan for the whole month. As a nurse, we need to be able, if we practice primary nursing, that means I have a set of patients that I'm taking care of for the month. I need to be able to plan for the entire month. When am I going to see who? And be consistent. Don't miss out anybody. And try to stretch and spread the appointments throughout the whole month so that the nurse won't be too busy in one day and having no patient to see the next. And make sure that we have to do the monthly assessment for the patient, draw the blood, do the special tests like PD adequacy, and do the transfer set or extension set according to the manufacturer's instruction, and then conduct patient care conference. On a daily basis, this is very important. Review the remote patient's treatment log. So a lot of time nowadays, the machine send the patient treatment information into the cloud. So the nurse all they have to do is to log on to the vendor's website, and they has full visibility of the patient's treatment. Unlike before, we have to wait until the patient bring in the manual treatment log to be able to see what's going on. So it's very critical for the nurse to spend time to review the patient's treatment log so that we can be proactive to do any troubleshooting. And then also on a daily basis, a nurse needs to be able to have some time set aside to handle patient emergency. If a nurse work 8-hour day, I would suggest them to keep themselves busy for 4 or 5 hours. And then some of the time they need to be able to unschedule. Patient can call and say, my catheter doesn't work, or I have peritonitis, I have an exit site infection. We cannot wait. We have to bring the patient in immediately. So if the nurse schedule a whole day with patient care meeting without any open time for emergency, then who can take care of the patient? Available to train new patient, and then limiting the number of appointments is a controllable thing by an individual nurse. So I strongly recommend them to manage their daily schedule wisely. Okay, so these PD patients don't come to see the nurse as often as the in-center. A lot of time they only come to see once a month. Okay, so in order for us to see the patient effectively and be well prepared, and we know the patient, it takes good preparation. So what does a nurse have to do to be well prepared? Review all the previous notes, including any phone conversation. See if there's any open issue. So when the patient is in front of us, we can discuss all the open issues. Review previous lab results and see if there is any need for redraw, like managing hypokalemia, okay, or the need to give IV iron at the clinic. And then be ready to review patient's medication list. So I usually look at the patient's medication list ahead of time, have the list with me, and make sure that I know what the medications are for, so that when I have a conversation with the patient, I can also do education. Hey, you're taking lisinopril. Do you know what that is for? Okay. Are you taking so many milligrams? How many times a day? So that we can also update our own medical record. And then communicate the patient's visit with the care team in case the dietitian or the social worker or the nephrologist would like to see the patient. Take this monthly opportunity to have a face-to-face time with the patient. And then during the visit, we have to do comprehensive assessment. And also, besides looking at the spot check, that day information, the assessment, also trended. We don't know. Maybe the patient might have lost a few kilograms from the last visit. We need to be able to catch that. Last time the patient has normal blood pressure. This time the patient is slightly hypertensive. We need to be able to see that. And hopefully we can also see that from their daily record that loaded onto the cloud, or the record that they keep on a daily basis. Ask open questions. Instead of asking, "You're feeling good, right?" The patient always say, "Yeah." "How are you feeling? Tell me what's going on with your dialysis. What dextrose strength have you been using? Do you have problem with the drain? How long does it take for you to drain? How long does it take for you to fill? Do you have you seen any bloody effluent? What's the color of your effluent?" Those are open questions, okay? Because we haven't seen the patient for an entire month. The only way to know what's going on with them is to allow them to talk about it. We have to do the blood draw, do the medication review, update the medical record, carefully examine the PD exit site. That's another passion of mine. I call it shirt up, pants down. Instead of just take out the dressing and take a peek at the exit site, look at the patient's abdominal appearance. That's the time that we might be able to see some hernia or subcutaneous leak. Okay, so take a look at the entire abdominal area. Do careful exit site check. If we need to, we can use a lighted magnifying glass to have a good look at the PD exit site. And then it's a good time to review site care technique and provide any education. When we see them once a month, use the opportunity to remind them, hey, what is the aseptic technique? Do you put your mask on? Do you wash your hands? Do you check your back? We have been having a lot of peritonitis lately, so please be extra careful. Do you apply antibiotic cream on your exit site? Those are everything that we can teach. And then administer any medication, and then perform any scheduled procedure, and then give them any dialysis supplies that they need to obtain from the clinic. And documentation. Complete all the necessary documentation following the company policy, no matter it's electronic or paper form. On a daily basis, I talk about the importance of reviewing the patient's online treatment log and then triage proactively. By doing that, we can prevent further complications. Say, for example, if the patient is on a cycler, we see that there's a lot of lost dwell time. It's taking long time to drain, or the patient is getting heavier and heavier. The patient has to use higher dextrose. We need to pick up the phone and talk to the patient. We might need to bring the patient in to do evaluation. Okay, and then check the email. Nowadays, we all get kind of burned by email, I think. But a lot of communication come from physician or even some of the patients, your manager can be through email. So check email on the schedule. You need to have some time that's designated for checking email. Attend daily huddle. Take some time to review new policies. Old habits die hard, but there's a need for the company to change the policy according to regulations or ISPD guideline. So the only thing that we know what to do to break that old habit is to review the new policy and proactively call the patient, talk to them, and see if they have any issues, any questions, in particular for the new patients or patients that are going through infection treatment, or patient just have a surgery, hernia repair. Hey, how are you doing? Is your wound healing? Do you have any leak? Do you have any bleeding? Be proactive. On a daily basis, we need to take some time to review lab results and communicate with the physician about the lab results. Take the order and execute the order, call the patient and provide information and instruction. Do the documentation. I think I have documentation in 4 or 5 times. Cannot stress the importance of documentation and communicate with the team. Anything about the patient, any change in the lab, or even as simple as, the patient's puppy just have some surgery and let's give the patient some love and care and ask the patient. Little things count. And then we need to be able to have time to do home visit when needed. And then other patient management tasks to do pre-ESKD education, to do urgent PD, be able to do phone triage, either patient call and we help them, or we pick up the phone and call the patient. And it's very important to have 24/7 on-call system. You don't know what it means to a patient when they are able to get a hold of us and ask maybe even a simple question. We just get a patient satisfaction letter and from a home hemo patient, not PD, but the same. The patient specifically wrote down, we are so appreciative of the fact that we can call the nurse anytime and the nurse will be able to help us over the phone. That makes me feel safe to do dialysis at home. Who doesn't like to feel safe? Think about they are given a procedure to do at home. And during the training, we have been telling them, hey, it is important for you to follow the procedure. You have to do aseptic technique to prevent infection, all these things. So it's important for them to be able to reach somebody just to verify that one step, just to be able to ask that question so that they know they are doing the right thing and they won't harm themselves. Or for a caregiver, for that matter, I wouldn't want to hurt my family. I don't want to make a mistake to hurt my family. Being able to call the nurse to say, hey, what should I do next so that I don't hurt my loved one is very important. And that concludes my presentation. Okay, if there's any questions, and then these are my references. Thank you so much.
Thank you so much, Joanna, for a very, very detailed and very strong presentation. I mean, God, you have a lot on your shoulders. I mean, to be a nurse and a manager of the unit, it's so many details. But as I said, a PD unit can never be a successful one unless we have a good nursing team as members and as managers. Thank you so much. And as you mentioned, we are now giving the chance for any one of the attendees to ask questions. So what do you think, Dr. Mazhar? Could you start by reading first the questions which were sent online? And you can start to read the first question so that the audience can benefit from the answers provided by Dr. Rivara?
Yeah, that's fine. Thank you. So thank you for both the presenters for a lovely presentation. A few questions that were already answered by Dr. Rivara. The first one was how to measure intraperitoneal pressure and when after drainage or before drainage. Dr. Rivara, do you want to speak out the answer, or should I just speak out the answer as well?
Yeah, I mean, we typically don't actually measure the intra-abdominal pressure directly because the exact number is not really that important. It's more just thinking about positioning in when we're treating complications that may require us to lower intra-abdominal pressures, just to put people in positions like supine positions. If you really do want to measure it, I mean, it would be transducing a bladder pressure as an estimate.
Thank you. And then the other question was, can calcium channel blockers cause chylomicronemia?
Yes, they can. In particular, amlodipine has been reported to cause chylomicronemia. Yes.
And then another question that was following was rationale of adding sodium bicarbonate. I think this was for the inflow pain.
Right. Yeah. So it's something, again, we don't do very often, but the rationale is to raise the pH up, towards neutral, because we think it's an acidic pH that basically irritates the nerves in the peritoneal space. And so if you raise the pH to neutral, that should hopefully resolve that.
And then the final question that was answered was, can we give pervasive subcutaneous or intraperitoneal in a PD patient?
Yes, I replied, I'm not aware of there being human studies on sub-Q or IP etylcalcitide. And certainly in the US, it's not FDA approved for that route. I think there have been animal studies, but I've not used it in that way.
Thank you. Then there's a comment from Professor Padilla from KSMC. He is one of our pioneers of saving their own lives in Tanzania. And he has a comment on, I think, the second presentation, which says, love your communication strategy with surgeons. What of nephrologists inserting the catheters? They become more involved in responding. I think that's with regards to insertion of peritoneal dialysis catheters done by nephrologists.
Yeah, it's a really good point. And I think compared to other places around the world, in the United States, so-called interventional nephrology or a nephrologist placing PD catheters is not very well developed. Our colleagues to the north in Canada have done this a lot more and have had a lot of success with it. I think around, especially also in the United Kingdom and places in Europe. And so I think it's a growing area in the United States now. And I think that PD catheters placed at the bedside for uncomplicated patients can be very effective. And I agree, there's more ownership on the part of the nephrologist of the catheter. The challenge becomes in individuals where they may have had prior abdominal surgery, the possible for adhesion, or individuals with hernias where you really need a sort of a surgeon to look at the abdomen and fix other problems. That's when you might need to engage a surgeon, but I'm totally with you.
Dr. Rasha, do you want to take the questions in the chat?
Well, actually, I have a question regarding the hypokalemia, Dr. Rivara. You said that, I mean, we all know that it's a major complication to have a patient with hypokalemia, and adding it to the solutions can be not septic, aseptic. What about having production of solutions with a bit of potassium from scratch? I mean, we know that there is magnesium, other electrolytes. Isn't it possible to be done for patients who are persistently hypokalemic? What do you think?
Yeah, I mean, I don't want to be like United States centric because I'm talking to an African audience here. We don't have in the U.S. any commercially available potassium containing dialysate, which is the problem. I think that it's something that's been proposed and it may be available in other places. I think if there was a commercially available solution or one that was, produced by a pharmacy in a sterile fashion, I think it would be very helpful. I think it's just when you talk about a nurse or a physician or a patient adding potassium to every bag, then you start, I think the risk of that outweighs the benefit.
So it's not a problem about the potassium itself, it's a problem from the manufacturer. So it's normal, that's understood. And I would like to ask Ms. Joanna, I mean, it's very well known that a lot of nurses are exposed, as you said, to burnout because they have to stay longer time with the patients and they can be compassionate. And so my question is, how can you balance between being compassionate and to have mercy, as you mentioned, like being there for the patient if they need to ask a question and to be supportive, and at the same time, not to go through a burnout for being just marrying your job? And do you find difficulties in having more nurses joining the PD unit? I mean, are there incentives which are encouraging new nurses to join the PD as a PD nurse?
Okay, so thank you for the question. It is not the easiest thing to separate, actually, the burnout for the nurse, especially when we take care of the patient day in, day out, we establish the relationship. So the nurse manager will be the person that catch that feeling during the one-on-one or by observation. And then if the nurse manager or the nurse him or herself aware that, then I will say that's the time to talk to social worker first and share that feeling. How do we, because a lot of nurses or healthcare worker, we always want to solve the problem for the whole world. We want them to be able to live a happy life, but sometimes it cannot happen, right? So that's the time that the nurse might need some counseling. Okay, in the United States, we have some employee counseling services that are free of charge, provide for employee. So to answer the question, I think one is a self-awareness. When the nurse, him or herself, is aware that, oh my gosh, I'm just too attached to the patient, I need to pull myself out. What should I do? Seek for resource. Or if the nurse manager or social worker, the team realize, I think the nurse is too involved. Let's help the nurse to think at the bigger picture. And I think that will be part of the solution. And then to recruit nurses I think is a global problem, right? We don't have enough nurses. And it's harder, I'm sorry to say that, but it's harder to find nurses with deep compassion. Usually it's more like a job. But taking care of chronic patient takes somebody with a lot of compassion and empathy to do a good job, to help the patient to be successful. And that can be done by a role modeling by a nurse manager. Okay, if the nurse manager spread that spirit, being very caring, and coach the nurse to be caring and yet set the boundary, I think that will help the nurse to be successful.
Excellent. I mean, I'm sure you're an excellent manager, Joanne. God bless you. God bless you.
Thank you. And I see that there is another question in the chat box. May I answer that?
Please go ahead. You can read it.
Yeah. So when the family has no interest in patient in home dialysis, how can we manage this? So first of all, does the patient need any help? Doing PD is pretty simple. A lot of patients can do PD totally by themselves. So yes, having good family support is important, but if the patient can do the procedure, do we really need a family agreement? And then the second thing is, you know, a social worker interviewing the family might be helpful to find out what is the concern, what is the barrier. Maybe it's just some misunderstanding. Some people might think, oh my gosh, you have something in the house with those fluid. Am I going to get sick? Am I going to be infected with the kidney failure too? So it's just some simple explanation, clarification might be helpful. And then secondly, do we suggest start manual PD first? I'm very biased. I say yes to that. Okay. I think a new patient, brand new, to a totally new medical procedure that they have to do at home, by teaching them manual exchange is going to be very helpful. Number one, they can see the yellowish fluid draining out. We teach them, see, this is like your pee-pee. And then fill them with some fresh solution and let it soak and dwell. I call it soaking time, okay, like soaking dirty clothes. So by watching this process, they have a full awareness of what is going on within the body and how this PD work before they transition to a machine, if they use a machine. Because once they use the machine, they really, especially if the patient connect and go to sleep, they don't really know what's going on. And then if something happened, do they really know what phase they are in and what might be the problem? You know, knowledge is very empowering. If we teach them manual exchange so they know and aware of what the process is, it will help to alleviate a lot of fear. And next thing is we talk about emergency preparedness. If there's a disaster, if there's an emergency, there's no power, PD patient has the advantage of being able to continue to do dialysis by doing manual exchange. If we teach them how to do manual exchange first, in case of emergency, hopefully they still remember the basic procedure, right? And actually in my practice, I usually ask the patient, even those they are on the cycler, I ask them to do manual exchange once a month, just to keep their hands, keep the muscle memory. So in case of emergency, they wouldn't be like, oh my God, I don't know what to do. Pick up the phone, or the line is busy, the nurse is not answering because a gazillion of patients calling the on-call nurse. So I'm a strong advocate for training patient on manual PD first.
Thank you so much. I mean, it's a very interesting point of view, the psychological direction or angle from manual PD. I love it. Thank you so much.
Thank you.
I would like to ask a final question, Dr. Rivara. I mean, it's well known that sometimes giving a day off from PD to patients could be good for their psychological well-being. So what is your experience regarding the long-term complications, whether infections or non-infectious? And of course, we know it has an economical addition, or it's a plus. So what is your experience regarding that?
So I think, there's, at least in the US, there's two separate issues. One is the sort of medical issues related to that, and the other is regulatory and financial. And I kind of won't cover the latter part, but I think from a medical perspective, the vast majority of patients on PD will do okay taking a day off, if not every week, then, maybe once a month. Or twice a month. And I agree that can be really important for patients' quality of life. If people have some residual kidney function, a day off is not going to be an issue. The only patients that I've really seen run into big challenges are anuric patients who really struggle with fluid overload. Even a day off, you might get behind and lead, chronically to volume overload and, potential need for hospitalization. But I think, again, with residual kidney function, you sort of free yourself from that a little bit. In the US, there are major other issues related to payment and quality metrics related to dialysis adequacy that cause complications for us here, but I'll spare you those details.
Okay, thank you. But we have heard that PD has gained less popularity recently in the United States. Is this true? And if it is, why do you think this is happening?
No, in fact, PD is growing very rapidly. And we actually we think that nationally, in the US, something like 15 to 17% of all dialysis patients in the US are now doing peritoneal dialysis, whereas 5 or 8 years ago, it was 10%. So it's actually gone up quite a bit. And there's many reasons for that, but yeah.
Why do you think it has increased like that, like you're saying in the US, and decreased in other countries where we had big percentages? What happened?
Yeah. Well, I'm not sure I can speak to the other countries. In the US, it's been multifactorial. Number one, there have been big educational initiatives to educate young nephrologists and our trainees about the importance of home dialysis in the form of, you know, a program called Home Dialysis University that something like 75% of all our fellows in the United States attend every year now. There's a greater belief in the importance of home dialysis, in particular PD, amongst, again, I think the younger generation of nephrologists. The second reason is there's been more research, I think, published showing that from a quality of life perspective, home dialysis is as good or better in most cases than in-center dialysis. And then the third big piece is that the major payer in the United States for dialysis, which is the federal government through the Medicare program, has put into place financial incentives, both for nephrologists as well as for dialysis facilities, to grow their home dialysis population. So those are probably the big reasons.
Thank you. That makes sense. And actually, you're giving us hope that maybe we're going to follow your steps soon, because we really need it in our continent. And we are hoping that very soon we'll be able to have a very strong PD program in Africa. Are we having any other questions, Dr. Mazhar?
No, maybe just 2 clarifications from my side, and then we can close. So one, Dr. Rivara, with regards to the hernia operations. So once the hernia operation is done, and once you keep them off dialysis for a day or two, when you reinitiate dialysis or PD, do you do it while they are laying down? So do you do the exchanges while they're laying down, or should they be just up and about? And what is the risk of leakage or recurrence of the hernia if the latter has been done? And then second question is on EPS with regards to, so we know peritonitis is a major risk factor for EPS, and obviously the duration of PD is as well. But what about the concentration of the solutions that they use? So higher glucose concentrations, is that also a risk factor for developing EPS along with the other two? Thank you.
Great, yeah. So, I mean, in terms of first question, as a general point, anytime you're doing an abdominal surgery in a patient on PD, the longer you can wait to start PD again is going to be the best. And every patient's going to be different, related to their degree of residual kidney function, related to how much salt and water they're drinking, and potassium intake, et cetera. So I think I try to take an individualized approach with that. When people do restart, if it has been less than 2 weeks, I always restart in a supine fashion with low volume exchanges if they can tolerate it. And again, in patients who have residual kidney function, switching temporarily for a 2-week period to supine exchanges overnight using a cycler, for example, or if you're on CAPD, then doing a couple exchanges overnight, lying in bed for 10 hours with 1 liter, generally people are going to do okay with that if they pair it with dietary potassium restriction and salt and water restriction for that 2-week period. And then after 2 weeks from the time of surgery, I feel that it's generally okay to go back to full strength PD and in any position. In terms of the EPS and the risk of high glucose concentrations in the dialysate, I am not aware, just off the top of my head, of any research showing that association, but there might be. I just haven't done an in-depth review of that literature.
Thank you. I think, Naomi, you have a raised hand. You can go ahead and speak, and that will be the last question.
There are two who raised their hands, actually. But
Okay.
did you unmute them?
Yeah. Unmuted both of them. You can go ahead and ask the question, please. I'm not sure if it's an erroneous raised hand. Naomi, Kimosop, you can speak. Unmute yourself and speak, please.
I think you have to unmute, Naomi. You are on mute.
Maybe Kim is unmuted already.
Okay, so Kim, can you ask your question? Well, I guess there is a technical, I think.
Yeah, it may have been, yeah. Okay. So I think,
conclude, yeah.
sorry, Dr. Rasha, please go
Shall
ahead.
we conclude our webinar, please, Dr. Mazhar?
Yes. We're going to conclude now. Thank you very much to you, Dr. Rasha, for the excellent moderation, and thank you very much for eminent speakers for these extensive and wonderful presentations. There's a lot of compliments that are coming on in the chat, asking for slides and recordings. So we really appreciate both of your time when taking in the questions that came through. And we hope to have you again on our series of webinars in the future. Thank you again for your time, and we look forward for collaboration in the future. Thank you very much, Dr. Rasha, and everybody else, including the participants. Thank you so much, and have a good morning and evening.
Thank you.
Thank you.
Thank you so much.